Good morning, everyone. Today, our topic of discussion is blood gas analysis using ABG analyzer. ABG full form is arterial blood gas. Arterial blood gas analysis. It is a blood test performed by using blood from artery. A small amount of blood is required and it is taken using thin needles and syringes. It is used for diagnosing and managing patients' oxygen status and acid-base balance. The disorders of acid-base balance can cause serious complications in case of many diseases. It is also used to test the effectiveness of ventilation. Ventilation is like in case of mechanical ventilation, if the patient is comatose or in case if the patient is unable to breathe properly, so we provide ventilatory support to the patient, and and after seeing the analysis, ABG analysis, then we can know that the support we are giving is sufficient or insufficient. Information obtained from blood gas analysis. First of all, we can find out the acid-base status of the patient, which is most important. The next one is also we can find out the oxygen status, oxygenation, dissolved oxygen, and saturation of hemoglobin, and carbon dioxide elimination. And we can also know the levels of carboxyhemoglobin and methemoglobin also. So these are the things which information which we can get from the analysis. The indication of this ABG analysis are to assess the ventilatory status, oxygenation, and acid-base status of the patient. And the second one is to assess the response to an intervention. Intervention may be a procedure or a surgery at that kind. And the next one is regular electrolyte therapy establish pre-operative baseline parameters. So in order for before operations, we have to see that the acid-base balance and all the other parameters are within normal or within operable limits. So in order to see that, in order to do that, they used to provide electrolyte therapy and all. So after providing the therapy, we can do ABG analysis to see whether the therapy is working or not, and to find out whether the patient will be operable or not. And the next one is sudden dyspnea. Dyspnea is like difficulty in breathing, and the cyanosis is like the bluish discoloration of body due to decreased oxygen supply. Then usually seen in lips. Then abnormal breathing sounds. Sudden and unexplained tachypnea means fast and rapid breathing. That is tachypnea. So in this case, we can do ABG, and if there is any diffuse infiltrates in the chest X-ray, if there is any diffuse means large widespread infiltrates in the chest X-ray. That means the lungs are largely involved. Then we can advise ABG analysis to see whether the oxygenation and the ventilatory status are within normal range, and we can also find out the acid-base status of this kind of patients. Now, contraindications. It is contraindicated in case of Allen's test. Allen's test is actually it is a test, a medical sign used in physical examination of arterial blood flow to the hands. So it is like to see whether the blood flow in the hands are flowing normally or not. Okay, this test is done for that. Now, if it's negative, that means there is some compromising blood flow in the hands. Since we are going to take the blood from the radial artery for the test, it is advised not to do the test because there is some compromising blood flow, or blood flow in the hands are compromised, as indicated by negative results of Allen's test. Now I will show you the modified Allen's test after the slide. Now, in case of bleeding diastasis or any coagulation diseases, like and if the patient is taking any anticoagulants, or if like not anticoagulants, but if he is like if he or she is suffering from a disease which is which which lead them which give them difficult time to coagulate the blood. And AV fistula is arteriovenous fistula, and the next one is severe peripheral vascular disease. So if there is any severe disease of arteries or veins in the hand, then it's not indicated. The absence of arterial pulse. So if there is absence of pulse, then it is also not indicated. And if there is any infection to the site where the blood is to be drawn. So these are some contraindications of ABG analysis. Now we'll go to the components of ABG. First one is pH, to see the acid balance, acid-base status, and the second one is the partial carbon dioxide, the partial pressure of carbon dioxide. The third one is partial pressure of oxygen. Next one is bicarbonate. Fourth one is oxygen saturation, and last one is base excess. Sample collection. Now, before going to sample collection, we have to do the modified Allen's test. Modified Allen's test. Allen's test like the medical sign used in physical examination of arterial blood flow to the hands. Allen's test. Allen's test is actually the physical examination of arterial blood flow to the hands. This test is usually done before taking the sample, and we usually do the modified Allen's test. Okay, and I will tell you how to do the modified Allen's test. First, we have to elevate the hand, and the patient is asked to clench the fist for 30 seconds. Okay, then after that we will apply pressure over the ulnar and the radial arteries to occlude them both. Now the hand is still elevated, and the clenched hand is slowly open, and we can see the pale coloration of the hand. That is called blanch, the pallor of the hand. Okay, the hands will not be pink in color, it will be pale. Then after that we can release the ulnar pressure while the radial pressure is maintained. Now while we release the ulnar pressure, the color should return from pallor to rhubarb. Rhubarb is like the pinkish color within 5 to 15 seconds. So that is modified Allen's test. It is positive. That means the ulnar blood flow is intact and it's not compromised. But if the the conversion of pallor to rhubarb color, that is the pinkish color, is takes lots of time. When we release the ulnar pressure, then we can conclude that there is some compromised blood flow in the hand due to some compromised ulnar supply. So in this kind of situation, this ABG is not indicated, and the blood sample can be taken from other areas like femoral artery or brachial artery, not from radial artery. Okay. So that is modified Allen's test, and it should be done before taking the sample. Because it should be done because, like, let's say the ulnar is compromised, then when we take the sample from the radial artery, and if there is some complication and if the blood flow is compromised there also, then the blood supply to the hand will be cut off, and that will be a very serious situation. That's why it is not indicated. When negative Allen's test is there, then ABG is not indicated in negative Allen's test, and accurately in negative modified Allen's test. Now we'll go to the procedure of the sample collection. First, a proper blood sample for a big analysis consists of 2 to 3 ml of artery specimen collected anaerobically from peripheral artery. Anaerobically because if it's exposed to oxygen, then the oxygen level or saturation of the blood may change. So it is collected ideally from the radial artery in a heparinized syringe. In heparin syringe means in that syringe there is powdered heparin, and already heparin is preloaded in that kind of syringe. Okay, and heparin is used because of its anticoagulant properties. The blood which we collect should not coagulate before testing, so we put heparin so that it is not coagulated. Okay, and if there is no heparinized syringe, then we can heparinize a normal small syringe with heparin, liquid heparin, like the solution form of heparin. You can take that syringe and suck the heparin inside, and you can discard the heparin outside. Okay, after sucking it, then you can discard the heparin outside, and that also can be used as heparinized syringe. Okay. Now, ideally, glass syringes are preferred because gas exchange may occur in plastic syringe. Ideally. Now, bubbles should be evacuated promptly. Now, local anesthetics such as lignocaine can be used during sample collection, and ideally, samples should be analyzed within 10 minutes after collection. If repeated analysis is required, use a different site or insert an arterial line. Okay, we should not collect the sample from the same site. Now, I've already told you about the modified Allen's test, and it should be done before sampling. Now, common site of sampling is radial artery, most common, because it is smaller in size and easily accessible, and it can be compressed to control bleeding, and there is less risk for occlusion. And even if it's occluded also, there is ulnar artery to compensate for some time. So the next one is femoral artery, and we can also take from brachial artery also. Now, procedure. Holding the syringe and the needle like a dart is a must, and use the index finger to locate the pulse and insert the needle at 45-degree angle approximately 1 centimeter distal to the index finger. This is done this is done to the wrist after detecting the radial artery. Number 2 is advance the needle until a blood flashback appears. Then allow the syringe to fill to a appropriate level. Yeah, for the filling of syringe, you should not apply negative pressure to the syringe. It will fill by itself, and it should be allowed to fill by itself. And then number 3 is withdraw the needles and the syringe and immediately close or recap the needle to prevent air entry and apply firm pressure for sufficient time to stop the bleeding. Now this is easily understood. Now in case of hypertensive patients or patients taking anticoagulants, then this bleeding may be prolonged, like more than 5 minutes. So we have to see into it and we have to take care of it and transport the sample immediately to the laboratory and should be analyzed within 10 minutes for accurate results. So this is how sampling is done. Now complications of this sampling. There may be excess bleeding in the site, or there may be hematoma. Hematoma is like the swelling due to collection of blood. Okay. So there may be hematoma at the puncture site. There may be vasovagal attack with tachycardia and all, with increased heart rate and all. Then there may be nerve damage. When we try to puncture the radial artery, we may damage the nerves, so we have to be careful. And then there may be infection at the puncture site. If the puncture site is not taken care of nicely, then it may be infected. Then there may be drop in blood pressure for the patient, or there may be swelling or pallor. Then there may be loss of consciousness also. So these are some common complications, not common, but then complications seen in sampling. Now this table shows the normal blood gas values. The first one is pH. In arterial blood, the pH is like 7.35 to 7.45, and for venous is 7.31 to 7.41. This is the normal range, and for capillary blood is 7.35 to 7.45. These are the pH for artery, vein, and capillary. Now the partial pressure of oxygen in artery is 75 to 100, and venous is 36 to 42, and capillary is less than arterial. And partial pressure of carbon dioxide in arterial blood is 35 to 45, and in venous blood is 40 to 50, and in capillary is 35 to 45. Now bicarbonate arterial blood is 22 to 26, in venous is 22 to 26, and capillary 22 to 26. And for base excess, +2 to -2, +2 to -2, +2 to -2 milli equivalent per liter. Now for saturation of oxygen, for normal arterial saturation is 95 to 100, and for venous saturation is 60 to 80, and the capillary is little less than this arterial, and it's given in percentage. So these are the normal blood gas values which you should remember. dissolved gas sensors. Now, ABG are now routinely measured with an automated analyzer. The basic components of such a unit are three electrodes, one for pH, one for partial pressure of carbon dioxide, and one for partial pressure of oxygen. Now, the electrodes are maintained at 37 degrees Celsius. Therefore, all ABG measurements are made at 37 degrees Celsius. First one is the pH electrode. It's known as SANS, measuring the potential difference between a measuring electrode and a reference electrode. From the voltage across these electrodes, the simple pH is calculated. So this is how pH is calculated. Now in the Severinghus electrode, partial pressure of oxygen, it employs a adaptation of pH measurement. Carbon dioxide from the blood sample equilibrates across a gas permeable membrane with a bicarbonate solution in a reaction that generates hydrogen ions. Now the partial pressure of the carbon dioxide of the sample is determined indirectly by sensing the pH change in this solution. And the next one is for the partial pressure of oxygen, and this is known as Clark electrode, and it determines the partial pressure of oxygen amperometrically. Amperometry means in chemistry is like the detection of ions in solution based on electric current or changes in electric current. So this is how the partial pressure of oxygen is measured. Now interpretation. The interpretation of ABG results can be done. Now we have to see these 5 parameters. We have to see the pH to find out whether it is acidosis or alkalosis, or is it within the normal range. The second one is we have to find out whether it is respiratory cause or metabolic cause. Then the third stage is the interpretation is the stages of compensation can be assessed. Now the fourth one is we have to see whether it is mixed disorder or simple disorder. In sometimes mixed disorders can be seen, where acidosis and alkalosis, this respiratory and metabolic are combined together. So mixed disorder, respiratory and metabolic are combined. Okay. And we have to see the oxygen status also. So these are the interpretation. First we'll go to the pH. Is acidosis and alkalosis present? So we have to look at, for this we have to look at the pH, and if the pH is less than 7.35, we consider it as acidosis, and if it's more than 7.45, we consider it as alkalosis. Now even if the pH is within the normal range, there may be acidosis or alkalosis with normal pH. In these cases, it is due to compensation mechanism. Okay, it is due to compensation mechanism for acidosis or alkalosis. Okay, so we have to know that there may be acidosis or alkalosis cases with normal pH. Now we have to ask that is the disturbance metabolic or respiratory. See, you see the table. Before going to the table, like if it is a primarily a respiratory disorder, then the pH and the partial pressure of carbon dioxide, the pH and the partial pressure of carbon dioxide change in opposite direction in case of primary respiratory disorder. But in case of primary metabolic disorder, the pH and partial pressure of carbon dioxide (PCO2) change in the same direction. So this is the thing you have to remember. Let's see. The first one is we'll see the table. The first one is acidosis, and due to respiratory, then the pH is decreased, but PCO2 is increased. In case of acidosis, respiratory related acidosis. Now the second one is acidosis, metabolic acidosis. In case of metabolic acidosis, the pH is obviously decreased because it is acidosis, and here the PCO2 is also decreased in case of metabolic. But in case of respiratory acidosis, the PCO2 is increased. So you have to see the difference, and the carbonate also is decreased. Now we'll go to alkalosis. In both the alkalosis, we have to see that the pH are all increased. Now let's go to the first alkalosis, the respiratory alkalosis. Then the PCO2 is decreased, and its opposite direction. See, and then in case of metabolic alkalosis, the pH is increased and PCO2 is also increased. They are in the same direction. See. So, and the carbonate also is increased. So, like we said before, in case of respiratory, pH and PCO2 opposite direction. But in metabolic, pH and PCO2 in the same direction. See, respiratory opposite direction, pH and PCO2, and this also respiratory opposite direction, pH and PCO2. But in case of metabolic, pH and PCO2 same direction. See, it's decreased, both are decreased, increase, both are increased in metabolic. Now we'll go to the next slide. Now we have to check for compensation. These are some expected compensations with the disorders. First one is for metabolic acidosis. In case of metabolic acidosis, PCO2 will decrease like around 1.25 millimeter of mercury per millimole per liter decrease in bicarbonate. In case of metabolic alkalosis, in the second metabolic alkalosis, then the PCO2 will increase 6 millimeter of mercury per 10 millimole per liter increase in bicarbonate. So these are the expected compensation, and for the respiratory acidosis, the first one is acute. For acute, the bicarbonate will increase 0.1 millimole per liter per mmHg, means millimeter of mercury increase in PCO2. For chronic, bicarbonate will increase 0.4 millimole per liter per mmHg increase in PCO2. Now this is for respiratory acidosis. Now we'll go to respiratory alkalosis. In case of alkalosis, in acute phases, the expected compensations are bicarbonate will decrease 0.2 millimole per liter per mmHg decrease in PCO2. And in case of chronic respiratory alkalosis compensation, in case of chronic, the compensation will be bicarbonate will decrease 0.4 millimole per liter per millimeter of mercury decrease in PCO2. So this is the expected compensation for the disorders. Now we'll go to anion gap. Anion gap should be calculated when there is metabolic acidosis is present. So it denotes the difference between the measured cations and anions, and it signifies the unmeasured anions. And here the unmeasured anions consider the anion gap. The formula is anion gap is equal to ions of sodium plus potassium minus fluoride plus ions of chloride plus bicarbonate. So this is how we will calculate the anion gap. Now reference level for anion gap is 12 plus minus 2 millimole per liter. This is the reference level. The unmeasured anion normally present in the plasma include anionic proteins, phosphate, sulfate, and organic anions. This will constitute the anion gap. Now, when acid anions such as acetoacetate and lactate accumulate in the extracellular fluid, the anion gap increases, causing a high anion gap metabolic acidosis. Now the next one is mixed disorder. In case of mixed disorder, it occurs when there is more than one primary acid-base disturbance present simultaneously. And in this this mixed acid-base disturbance are usually seen in critically ill patients, in intensive care units, and also in elderlies. So next we'll go for oxygenation status. We have to look out for PCO2 and we have to look out for oxygen saturation. And for the normal oxygen saturation, it should be within 95 to 100. And oxygen saturation also can be measured using this pulse oximeter, which is an easy non-invasive form of technique to find out this oxygen saturation. Now here is a nomogram, an acid-base nomogram. Here we are plotting the y-axis is plasma bicarbonate, its unit is millimole per liter. The x-axis is pH. As you can see, in case of, let's discuss about this metabolic acidosis and respiratory acidosis. Let's discuss about this acidosis first. Okay. Now, in case of acidosis means usually the pH will be low, so it will be in this area. Okay, this area. Now, in case of metabolic acidosis, the plasma carbonate is low here. But in case of respiratory acidosis, the plasma bicarbonate is a little higher, is on the higher side. Then we also have plotted this one, the partial pressure of oxygen. These are the partial pressure of oxygen. These are the partial pressure of oxygen. Then, in case of this one, alkalosis, we find that the pH are in the higher side. So in this area, here in case of metabolic alkalosis, we can see that the bicarbonate is also in the higher side. In case of respiratory alkalosis, the bicarbonates are in the lower side, and this plot is for partial pressure of oxygen. The partial pressure of carbon dioxide. They are also in the lower side, as you can see. So around 10, 20, 30, like that. That is for respiratory alkalosis, and 40, around 40 for metabolic alkalosis. So this is the nomogram showing the disorders where this plasma bicarbonate, partial pressure of carbon dioxide, and pH are plotted. Now we will go to see now we will go and see how the sampling is done and how the sample is collected, and after that how we put the sample for test using the analyzer.